Hi class, today we're going to be talking about drains, surgical drains, which is very appropriate for this particular setting, which is a trauma hospital, a level 1 trauma hospital for 5 different states. Anyway, drains, we're going to be talking from head to toe, and it's going to be brief. This is a very brief in-service, trying to get you guys back on the floor. Anyway, drains head to toe, in and out, talking about open or closed drains, active passive drains, or sump drains. Beginning with the tip top of the head, we've got ventricular drains, which can either be internal or external. An external ventricular drain, draining the CSF away from the ventricles of the brain, because we know that the swelling of that can impair cognitive ability, etc. So you can also have an internal VP shunt or ventroperitoneal shunt or ventral pleural shunt or whatever, but it's actually just draining away excess fluids, which that is what drains actually do. Drains take away pus, blood, bile, air, serum, serofluids, lymph edema, lymph fluids, saliva, anyway, used to kind of minimize the dead space that's created. In a surgical process, usually a drain is not placed directly in the surgical incision, but to the side. And basically it does not necessarily make it less infection prone, but it does take away the extra fluid, thus allowing the tissues a little better chance of healing or apposition. So, started with the head. Then we go to the nasogastric tube, which you can use a feeding tube via the nasogastric route. You can, after abdominal surgery, quite honestly, they like to have the gut rest a bit, and so a nasogastric tube is to either low intermittent or continuous wall suction. Then we're going on down, usually when you have neck surgeries, which are kind of a tender tissue area, they usually put in what is, I call a soft active drain, like a JP or Jackson Pratt bulb, which actually is pulling suction, but it's not the suction attached to the wall. Or you do a Penrose drain, which is an open drain that allows for the drainage just to happen. And Penrose drain was actually invented by Dr. Penrose. Looks basically like a tourniquet for placing an intravenous line. So moving on down, of course, we can have the tracheotomies. There's the new laryngeal tubes that we're seeing with our neck dissections. But let's move on down to the chest. And so chest tubes, quite honestly, used for blood, air, re-expansion. When you've had injury, quite often we see chest tubes here in this trauma center. Also, spontaneous pneumothorax, when you think of the long, thin, very young, thin man who has a spontaneous pneumothorax, and we put in what is called a Heimlich valve, but we're actually finding some new information from the atrium, the chest, people who developed the chest tubes and the chest drainage system. So kind of new things coming about. Things you want to remember about a chest tube. They shouldn't be so scary, right? Yes, they're a drain, and a drain is always, you need to be aware, but just think of it, the bigger chest tube is draining big blood, thick, clotty kind of stuff. The medium chest tube, which is 26 to 36 French, is draining fluid, and then usually below a 26 French, a little smaller tube is air. So we're draining air from that, or pulling out air. Beyond the chest tube, we're going to go to the gut, and we can look at G tubes or gastric tubes for feeding, GJ tubes, gastric jejunostomy tubes for feeding, J tubes themselves. Difference between both of those, with the G tube, usually you start out there. You start out, people want, when you're supplying them with nutrition, your stomach is better able to handle that, right? But if you are prone to aspiration, usually the tube is generally moved down to the jejunum, which has a lesser chance of aspiration. But I have read that it is a higher chance of infection. So, weighing one or the other. That's the thing about drains. You want to make the most appropriate drain for for the purpose. So why a drain? Okay, why we're draining stuff. Where to put it, where is, the abscess or the fluid-filled chamber. And then another thing to remember is drains they're invasive. It's like a urinary catheter. So you have this invasive tube in your body, you'll want to get it out as soon as you can. Let's move on to the T-tube, which is basically after a gallbladder surgery or a gallbladder procedure. You know, you've got your liver up here, you've got your pancreas down here, and the gallbladder sort of in the middle, and then you've got the common bile duct. Well, quite often that duct gets plugged up. So they put in a T-tube that allows, it sort of makes a fistula, makes an opening, and keeps that patent so you don't have clogging, because you want to be able to eliminate that bile, and you want it to flow where it's supposed to flow and not get backed up into the gallbladder or the liver. So T-tube is placed. We are doing a lot of interventional radiology tube placements, which are kind of cool. A lot of them are called the pigtail, which commonly put in urological procedures, opening a nephrostomy tube, etc. So radiologically placed tubes are kind of neat. They can actually be put to drainage, or they can be put to suction. I actually just saw one the other day that was a small tube. This woman had a lot of fluid around her lung. They placed this radiological tube, and we put it to suction, just like a chest tube. So it was kind of interesting. So you can do that with a port, etc. Moving on down, suprapubic catheters, which we commonly see in this area just from urological trauma. Foley catheters. Back to the basics of what we do see a lot here are the VAC dressings, which are basically a drain to suction. And they're the spongy material that goes over a very large wound and to promote healing from the outside in. And we're going to see a new one of those, and it's going to be impregnated with either antibiotics or some other healing medication that promotes the healing a little bit quicker. So basically drains, you've got the open, which allows just, passive drainage, which is the Penrose red rubber cath. You've got the closed system, which is like the Jackson Pratt drain, or the Hemovac drain, which is the accordion drain that goes in commonly to a total knee or a total hip. You have got active or passive. Passive just sounds like gravity. It's just going to flow with gravity. Active is to suction, whether it be a bulb suction like a JP or to a wall suction. Just understanding that sometimes that suction can be too much, where the drain will adhere to the tissues and can cause some tissue erosion. So problematic areas are tissue erosion, ischemia, the drain itself can clog, the drain itself can break. So a lot going around there. It can be, mechanical, certain elements of the drain itself can malfunction. So understanding what the drain is for, what is supposed to be draining, where it is, just basic elements of knowing what is going on with that drain. So that is my brief in-service. I am going to offer everybody the chance to go to interventional radiology. It's usually a 2-hour time frame where you can see either pleural drains placed, you can see some of the urology drains placed, you'll be able to see a G-tube, a J-tube, etc. So we are going to try and work on a schedule that way, and just wanted to hit the head to toe. We're about done now. So thank you very much. If you have any questions, you ask me, and I'm just handing out a little evaluation form. Just let me know kind of what you wanted to learn today and what we can learn in our next very brief in-service. Thanks a lot.